swap over.
I beg to move that this House do now adjourn.
The question is that this House do now adjourn Alex Easton on provision of NHS dentists. Alex Easton.
Thank you, Madam Deputy Speaker. I'm grateful for the opportunity this evening to draw to the attention of the House to an issue that affects millions of British people and families right across our country, the current state of NHS dental services throughout the UK. Our NHS dentistry, from which I and so many others in North Down in my constituency have benefited, just as countless people across our United Kingdom have, was founded on a basic principle, indeed I would call it a promise, that everyone, regardless of income, background or postcode, should be able to access essential dental care when they need it. It is a foundational pillar of our wider health sentence and system, and a critical measure of our nation's public health. Every member of this House would do well to ask where that basic principle and promise now stands in Britain in 2026. Our NHS dentistry is under severe and unsustainable strain. This evening I want to speak plainly about where we are, why and how we have reached this point, how it is affecting both patients and professionals alike, and what must be done if it is to be resolved and sorted out. We are truly serious about saving NHS dentistry for future generations. So where are we now? Across North Down, across Northern Ireland, and indeed across the whole of the United Kingdom, the picture is deeply disturbing and far too painfully familiar. Finding an NHS dentist has become increasingly difficult. My constituents in North Down, like so many in England, Scotland and Wales, are joining waiting lists that stretch for months and sometimes cases even for years. Some are ringing multiple practices in their area only to be met with the same response: we're not taking in NHS patients. Others are told that their only option is to go private or to travel long distances simply to access basic dental care. I would love to tell this House that this is a marginal problem affecting only a small minority. It is becoming more and more lived reality for British families, older people and children in towns, cities and rural communities across England, Scotland, Wales and Northern Ireland. Whereas the British reality is fewer practices offering NHS appointments, growing backlogs of routine checkups, increasing numbers of patients turning up at GPs or accident emergencies with dental pain and infection, places that were never designed for dental care.
I thank the Honourable Member for giving way. Does the Honourable Member consider that part of the problem as to why dentists are not offering NHS appointments is because contracts have not been updated, and perhaps dentists feel that when they do NHS work, they are not being properly paid?
Thank the Honourable Member for his intervention, and that is certainly one of the major issues that does need to be addressed. And shockingly and frighteningly, use of people resorting to DIY dentistry because their pain is so great that they simply cannot afford treatment. No MP can sleep easily in 2026 when British people are pulling out their own teeth at home. Our NHS system is under pressure. So why is this happening? Isn't the reality that funding has not kept pace with demand, or with the reality of the cost of prioritising high-quality dental care?
On the subject of funding, would my Honourable give way? Thank you, and I commend the Honourable Member for securing this important debate. In Amber Valley, recruitment and retention continue to be the main barriers to NHS dental access, despite £240,000 of additional funding that I've managed to secure from Derbyshire locally. Does the Honourable Member agree with me that the Minister should set out how the new NHS dentistry contract will include concrete funded measures to increase the workforce so that my constituency and his and those up and down the country will finally see the material improvement in access to NHS treatment.
Thank the Honourable Member for her intervention and congratulations for securing that funding, and I totally agree with all her sentiments, and maybe you can give me a clue how to get that funding as well for Northern Ireland. Sorry.
No use, because it wasn't me that you were referring to, but you've got lots of time, so enjoy your time. Mr Easton.
Madam Deputy Speaker, we all understand that the regional differences in how dental contracts work across our UK nations. However, a common theme is identified. Many of our NHS dentists feel they are being asked to do more to address complex needs with resources that simply do not match the reality on the ground. My research indicates that in some parts of the United Kingdom, that very way dentists are paid actively works against the long-term interests of patients. The current system rewards quick, high-volume work rather than the kind of long-term preventative care that is essential if we are serious about keeping mouths in Britain healthy. Many of our newly qualified dentists tell me that the NHS contracts are inflexible, over-bureaucratic, and in many cases financially unsustainable for anything beyond the most basic level of service.
On that point,
To give way to the member.
thank you, Madam Deputy Speaker, and the honourable member is making a strong case. The number of dentists leaving the NHS across the UK is driven by chronic underfunding and the failed dental contract. And last month, the Minister suggested that long-term fundamental reform might only be introduced from 2027 onwards. Does the honourable member agree that that reform must be brought forward as soon as possible? We need clarity on when. And does he agree that the one-third cut in real terms of the dentistry budget that we've seen since 2010 must be reversed by this government?
Thank the honourable member for his intervention, and I agree that reforms need to be brought forward a lot quicker. What is the result? I tell you what the result is. We are seeing a growing number of dentists reducing the amount of NHS work, handing back NHS contracts altogether, leaving the profession earlier than they intended. I do not for one moment accept that this is a question of dedication or commitment. Our dentists, dental nurses, therapists and practice staff are putting in a hard shift day after day in a system that too often feels stacked against them. Their burnout is real. Their morale is low. They are left apologising to patients not only in North Down but right across the United Kingdom for a system that is not of their own making and not under their control. There is a human cost here. It must never be reduced to a dry debate about contracts and budgets. Behind every statistic is a person. Let us think together of the elderly person in a British care home struggling to eat properly because they cannot get regular dental visits and the dentures no longer fit. The British patient trying desperately to get their child seen for a broken tooth only to be told that their nearest NHS dentist is basically many miles away. The low-income British citizen, the person who never missed an NHS check-up, now being told they can only be seen privately at a fee far beyond their means. Let me be absolutely clear, dental health is not a luxury, it is integral to our overall health and well-being. The facts are stark. Poor oral health is linked to heart disease, diabetes, respiratory infections and complications in pregnancy. Untreated tooth decay can cause severe pain, days lost from work, days lost from school, and a serious blow to confidence and mental health. And let us be honest, inequality runs through this story like lettering in a stick of rock. People on low incomes and those living in our most deprived areas are more likely to suffer the consequences of poor oral health and less likely to be able to escape. Regrettably, the British reality in 2026 is this: children from our most deprived communities are still far more likely to be admitted to hospital for tooth extraction under a general anaesthetic, and in an experience that is traumatic, in many cases entirely preventable. I recognise that health is a devolved matter and that 4 nations of our United Kingdom have taken different approaches to organising and funding NHS dentistry. In Wales, new contract models focused on prevention and patient-centred care are being piloted, yet as I understand it, patients still report serious difficulties in finding an NHS dentist and securing regular checkups. In Scotland, Yes, a good way to the Honourable Member.
The Honourable Member for giving way. Is he aware that it is the Eastern region that is the only region of the UK that has no dental school, which severely impacts the availability of dentists? And would he join me in pressing the Government and the Minister to do all they can to expedite a proposal by the University of East Anglia to open a new dental school in the Eastern region to help address that recruitment and supply issue?
The Honourable Member, he makes a valid point, and I would urge the Minister to take that point up for him. In Scotland, efforts have been made to reform the system and expand free dental care for certain groups, but workforce challenges persist, as do the difficulties of sustaining practices in rural and remote areas. In England, some of the most acute access problems are reported. Many practices say that the current contract does not reward preventative care, nor does it adequately reflect the complexity of modern dentistry. In Northern Ireland, we have our own contractual framework. The concerns we hear, however, are strikingly familiar: rising costs, mounting workforce pressures, and an unsustainable gap between what the NHS pays and what actually costs to provide care. I believe Northern Ireland is at a crossroads in NHS dentistry. We see a steady erosion of NHS dental provision, more practices moving to private models, longer waiting times at those practices that remain within the NHS, greater pressure on community dental services, growing inequalities between those who can pay and those who simply cannot. But it does not have to be like this. The lessons we draw from Northern Ireland are equally applicable across the rest of the UK. So let us work with dentists, with patients, with commissioners and with independent experts to design a model, contract and funding model that can reward prevention and continuity of care, recognise the complexity of treating people with additional needs and vulnerable groups, support high street NHS practices at the backbone of accessible care, provide a clear, attractive pathway for young dentists to enter and to remain in the NHS focused practice. This House can shape what is needed in Northern Ireland and apply those principles right across the United Kingdom. So in conclusion, let me underline some urgent UK-wide actions. First, we need a realistic, sustainable funding settlement. Let us address this with honesty. If we truly desire a meaningful NHS dental offer, then this Parliament must fund it. Second, we must move beyond temporary uplifts and crisis top-ups and design a long-term settlement. That is the real question before us. And are we prepared to put NHS dentistry on a stable footing, not just for this Parliament, but for future generations? Thirdly, we must reform the dental contract with a new model, prioritise prevention, encourage regular checkups, fluoride use and early intervention, create clear incentives to take on new NHS patients, reward quality with a focus on outcomes and patient experience, not just through volume and throughput. Children, particularly those growing up in poverty, can benefit from school and community-based prevention schemes also. People with disabilities and complex needs can access the specialist attention and the longer appointments they require. Older citizens, including those in care homes, can receive routine, dignified dental care. We also need a credible solution focused on workforce planning, including workforce planning based on real need, not short-term firefighting, training pathways that support and prioritise NHS services, effective retention measures so that experienced staff are not driven out of the system. So in closing, the decline of NHS dentistry is not inevitable. We must honestly answer these questions. Are we prepared to drift into a future in which NHS dentistry is an optional extra while the majority are pushed towards private care? Or do we commit clearly to inclusive, universal NHS dentistry, which cost is not a barrier and where postcode lotteries do not determine your success? Let the UK lead in addressing this problem and let this House reaffirm for the whole of our country the enduring British principle that good dental care is not a luxury but the right and entitlement of every British citizen. Thank you, Madam Deputy Chair.
Minister Stephen Kinnock.
Thank you very much indeed, Madam Deputy Chair, and I congratulate the Honourable Member for North Down for securing this important debate today. I'd also like to thank the Honourable Member for his work in raising awareness of the challenges facing dental patients in his constituency and across the United Kingdom. It's vital that we all work together across the 4 nations of the United Kingdom to tackle the long-standing problems that adults and children have been facing in accessing an NHS dentist when they need one. And I'd also like to thank other members, honourable friends and other members, for their powerful contributions today. I know that access to dentistry is a matter of continuing concern to members and their constituents across this House. The concerns that members have raised support the many testaments I've heard directly from patients, dentists, members of the wider dental team and their representatives. In July 2024, we inherited a dental system in crisis. This is evident from the Adult Oral Health Survey of 2023, which provides the first picture of adult oral health in England for more than a decade and shows poor oral health in adults. Among adults with their own teeth, over 2/5, 41%, showed evidence of obvious decay. 93% had some form of gum disease, and 19% had one or more potentially urgent dental conditions. This government is determined to fix this. Our 10-year health plan confirms our commitment to transforming NHS dentistry so that it is fit for future generations. And we have established a platform for future success by reducing the NHS dentistry underspend from 392 million in 23-24 to just 36 million this year. The decrease in underspend is leading to an increase in NHS dentistry, but I absolutely accept that there's still a long way to go. Over the last 18 months, the government has made great strides in improving NHS dentistry, not just for patients, but for the dental workforce delivering oral care to our nation. My immediate priority when taking up this ministerial post was to ensure that people who need an urgent dental appointment were prioritised and able to access the care they needed quickly. And to me, it's essential that we direct care towards those who need it most. We all have a duty to reduce health inequalities, which are sorely felt in NHS dentistry. That is why, since last April, we've been making extra urgent dental appointments available to ensure that patients with urgent dental needs can get the treatment they require. These extra appointments are available across the country and are more heavily weighted towards areas where they're needed the most. We're also incentivising high street dentists to offer further appointments to maximise the availability of care to those in need of urgent care. And we recognise that access to NHS dental services remains a challenge in certain parts of the country. In addition to our urgent appointments, integrated care boards are recruiting dentists through the Dental Recruitment Incentive Scheme known as the Golden Hello Scheme. This initiative offers a financial incentive to encourage dentists to work in underserved areas for a minimum commitment of 3 years. This government has heard dentists' concerns that they don't think the current dental contract is fit for purpose. Talks are underway, including with the British Dental Association, to scope our plans for potential changes. We remain open-minded and keen to consider how different payment models could best improve the delivery of care to dental patients. In reforming the dental contract, we want to focus on matching resources to need, improving access, promoting prevention, and rewarding dentists fairly. We also want to enable the whole dental team to work to the top of their capabilities. But reforming the dental contract is a significant challenge, and there are no quick fixes or easy answers. That's why in our 10-year health plan we committed to fundamental reform of the dental contract by the end of this Parliament, but with significant steps in 26-27. Talks are underway with the British Dental Association, and we're making progress on these matters. In addition to delivering fundamental contract reform over the longer term, we have already made significant progress through our 2026 reforms. We held a public consultation last summer on changes to the current NHS dental contract to address the pressing issues that dentists and dental teams said they're experiencing. The government's response, published in December, took account of the views of the dental sector as well as people with lived experience. Our reforms will utilise the existing dental contract to deliver the right care to the right people while incentivising dentists to provide more NHS care. And by prioritising patients with the greatest needs and more efficient use of dentist time, The changes will ensure that NHS dentistry budget delivers value for money for the taxpayer. So, from the 1st of April, we will start to implement the reforms. This will include, for the first time, we're introducing provisions in the dental contract to embed urgent dental care appointments, making it easier for patients to access this care. And we are increasing payments to dentists to deliver this care from £42 on average to £75 for that unit of dental activity. Providing new treatment pathways for patients with complex treatment needs, paid at a set fee of around £250 or £700, depending on the pathway, whilst enabling and encouraging dentists to deliver more preventative care. These reforms will make full use of the existing dental contract to ensure patients receive the right care at the right time, while creating clear incentives for dentists to provide more NHS care. And as I say, they will kick in from the 1st of April. There are more than 38,000 dentists registered in England, of which 10,700 full-time equivalent general dentists are delivering NHS care in England. As we take forward our reform programme to rebuild NHS dentistry, we are also clear that strengthening the workforce is key to achieving our ambitions. This government is committed to publishing a 10-year workforce plan to set out actions to create a workforce that's ready to deliver the transformed service set out in our overall 10-year health plan. And while we are taking steps to increase the capacity of our dental workforce. As announced in our 10-year health plan, we will make it a requirement for newly qualified dentists to practice in the NHS for a minimum period. We intend this minimum period to be at least 3 years. That will mean more NHS dentists, more NHS appointments and better oral health.
I thank the Minister for giving way and highlighting the need for the dental workforce to be strengthened. We have a dental desert in East Anglia, and the University of East Anglia stands ready to open a new dental school, has permission from the General Dental Council, but is awaiting the funded undergraduate dental places that would be needed to start training new dentists from 2027. Will the Minister set out how these places will be made available on the basis of regional need, so dental deserts such as the East of England can start to build a sustainable dental workforce?
I thank him for that intervention. I'd like to congratulate the University of East Anglia for its accreditation through the GDC as a dental school. I think that's a huge step in the right direction, one that we strongly support. The next step is that the Office for Students has to actually allocate places. One point I'd like to make is there haven't been any new dental school places funded by the government since 2007. I am fighting hard for those dental places to be made available. We are, I think, quite close, I hope, to be able to sharing some positive steps forward on that point. The OFS makes the decisions about allocating the places, but they do take advice from ministers. So my counterpart in the DFE and I will be sending a letter to the OFS with some advice on how they should make their decisions about where those dental places should be made available. But of course, the fact that UEA is a new dental school is an important factor in those considerations. One other point I wanted to make on workforce is that I really welcome the General Dental Council's recent announcement confirming the appointment of a new provider for the Overseas Registration Exam, the ORE. The new arrangements are set to more than double the annual number of dentists able to join the register via this route. This represents a significant step forward in addressing workforce shortages and NHS patient access. I met with the General Dental Council at the end of last year to discuss their comprehensive plan to address the current ORE waiting list and to urge them to get that waiting list sorted because, frankly, the backlogs were not acceptable. And we are looking then at an increase in the supply of overseas qualified dentists joining the GDC register. I expect the measures to be taken by the GDC to deliver substantial improvements to the international registration processes, enabling increased numbers of overseas qualified dentists to join the register more swiftly and efficiently. Turning on to the issue of prevention, we know that prevention is better than cure. Alongside the urgently needed reforms to treat existing poor oral health, I'm committed to improving oral health in this country, not just for children, but the wider population too. Water fluoridation is an effective public health intervention for reducing the prevalence of tooth decay and improving oral health inequalities. Under this government, we will see much-needed expansion of water fluoridation in the northeast of England, with further feasibility studies for other parts of the country. We're already investing in ICBs to support supervised toothbrushing for 3 to 5-year-old children, and our innovative partnership with Colgate-Palmolive will support up to 600,000 children to develop good oral health habits for life. We are working with all sectors of the food industry to make further progress on reducing the levels of sugar in everyday food and the everyday food and drink that people buy. This is to ensure it's easier for people to make healthier choices. Oral cancer and periodontal diseases are directly caused by tobacco. Dental teams and the local stop smoking services can work collaboratively in a variety of ways. So, Madam Deputy Speaker, we have already made some important progress, but I absolutely accept that there is still a lot more to do and a long way to go. We are determined to ensure that everyone who needs an NHS dentist can secure one. Delivering this ambition will take time, and it is vital that we put in place solutions that work for both patients and the dental professionals who care for them. Thank you.
The question is that this House do now adjourn. As many of that opinion say aye. Aye. The ayes have it. The ayes have it. Order, order.